Thanks, Olivier. So you would have seen my photo in lots of the photos at the beginning. So I've actually been with Frontier since 2010, and I do recognise a few faces in the crowd, so it's really nice to see you. And yeah, as Olivier said, I've been working predominantly on social cognition and behavioural changes. So as Rebecca said at the beginning, when we're thinking about dementia, we're thinking about it as an umbrella term. So there's lots of different subtypes. Alzheimer's disease is one and frontotemporal dementia is another type. And I think you would all know that when you're talking to friends and family and people in the general community, most people think, when they're thinking of dementia, they think of Alzheimer's disease. So they think of memory problems. And that's certainly what happens in Alzheimer's disease, is that people have difficulties with memory. They might have problems in recognising people, remembering recent events. But what we call social cognition is relatively well preserved. And this is quite different to what we see. So if you think about cognition, this is sort of the test that you might do, we do with patients here when they come into the clinic, the sort of paper and pencil or computer-based tests to look at different skills. And so when we're talking about cognition, it's things like how good people's attention is, their language skills, like if they have problems in terms of naming things, how good their memory is, visuospatial abilities, like Rebecca was talking about, can they copy a cube, can they draw a clock, and planning and reasoning and those sorts of things. And what we see in people with frontotemporal dementia, and particularly in behavioural variant frontotemporal dementia, is that they can often do really well on these tests. So sometimes your GP might have done some basic tests asking them what day it is, do they remember things, and often people with frontotemporal dementia can do really well on these tests. And so that's why we've been looking outside of cognition and looking at more social cognition. So what made us look at social cognition? Well, first I'm going to talk a little bit about the specific symptoms that give us a hint that there might be something wrong with social cognition in these patients. And then I'm going to explain to you exactly what I mean by social cognition. So the first thing that's really important to know is that every person with dementia is different. Even if you're talking to someone else at lunch and you both care for someone who has behavioural variant frontotemporal dementia, they might have completely different symptoms. So I'm going to talk to you about all the different symptoms that we see, but it's certainly not a checklist. We wouldn't expect to see all of these in every single person. But what sometimes you see in behavioural variant frontotemporal dementia is things like a lack of an emotional response. So they might not seem as happy or as sad anymore. They might get some bad news and not seem upset by it. They might become more socially avoidant, so not interested in going to social events or spending time with their grandchildren. As Rebecca said, they have some changes in terms of eating and decision making. They often don't have insight into their problems, and so what we mean by that is that everyone can see that they're different in terms of their behaviour and personality, but from their perspective there's nothing wrong with them and they're not concerned or upset by it. They might seem more cold and lose empathy towards other people. They can have reductions in terms of motivation, so they might be less interested to take part in their hobbies. They might be less interested in doing things day to day and just sit there until you ask them to do something. And they can become more disinhibited. So like Rebecca said, things like approaching people in public, maybe swearing when they never used to do those sorts of things. And they can become perseverative. So what we mean by that is getting into routines or doing the same thing over and over again. So like I said, this isn't a checklist. It's just you might see some of these things in some people with behavioural variant FTD. Now in semantic dementia, really a lot of the research focused on the language problems, and there was a real, a lot of research was done looking at the language difficulties, why people had problems in terms of understanding language and naming things. But we now know that it's not just restricted to language. So in people with semantic dementia, they can also show some of these behavioural symptoms. and symptoms that impact on their ability to interact with other people socially. So they might have problems in terms of recognising people. Say you're going to a wedding and there's people that you haven't seen for a very long time, they may not recognise those people anymore. They seem to have problems in terms of understanding emotional expressions, so they might not recognise what a frown means anymore, or they might not recognise if someone's upset with them anymore. They can also show problems in terms of motivation. They can show some of these repetitive behaviours or rigid behaviours, like only wanting to eat the same thing every single day. There's some clinical observations that say that they don't seem to experience fear in the same way, so they might become a bit more danger-seeking. And they can also have exaggerated reactions to things like smells and sounds, so they might experience these phenomena in the environment a little bit differently. And what we know in terms of semantic dementia is that often these symptoms can come unexpectedly for carers. So a lot of the information that you get when you first get diagnosed really focuses on these language problems. And so people may not realise that these behavioural changes and social changes are also part of the disease. And it seems that that can cause a lot of stress and burden for carers because they don't really know how to manage it and they don't really have techniques. So in some ways these social and behavioural changes can be even more difficult. So what is social cognition? It's talking about all of the skills that we rely on in order to participate in day-to-day social interactions. So if you're at a dinner party, you need to recognise the people who are there. You need to understand how they're feeling. So are they happy or are they sad? So if you think about this lady here, she's clearly very happy, but how is this man feeling? Does he think that the food's not very nice? Is he annoyed at what she's just said? And to do that, we rely on people's facial expressions, but also things like non-verbal cues, so body language or the way people speak. We also empathise with people, so if someone's at a dinner party and they say, oh, I've really had a terrible day at work, then the way that you respond to that is going to be quite different to if someone's quite happy and in a good mood. And it also includes things like social norms, so knowing what's appropriate in different situations. So it might be completely fine if you're having dinner at home to, sneak someone's chip off their plate. But if you were doing that with some work colleagues, probably not appropriate. So what we can see is these are all quite complex things that we need to do to behave appropriately in social situations. And actually we do this without a lot of effort. So a lot of these things we just do automatically. We don't even need to think about it. You don't actually sit when you're looking at someone and think, oh, is that person sad? Are they angry? Are they upset? We just do this automatically as we're engaging in interactions with people. Now, what about progressive non-fluent aphasia? Well, we know a lot less about this group in terms of their social cognition, but that is because, again, there's been a real emphasis on language problems. So because, as you can imagine, they have quite difficulties in terms of their speech and expressing themselves, there's been a lot of emphasis on that, and people haven't really looked at these other aspects of social cognition. But some of the work that we've been doing has shown that people with progressive non-fluent aphasia might also have some subtle difficulties in recognising emotional expressions, changes in motivation and reduced empathy. So it's not to the same extent as what you would see in behavioural variant frontotemporal dementia, but it seems that they might also have some of these challenges. So really you can see that if you think about that dinner party setting, there's a real overlap between how people with frontotemporal dementia are presenting and these behavioural symptoms that we've noticed that might be because they're having problems with social cognition. So problems in terms of understanding how people are feeling, knowing what's appropriate in different social situations. So why might social cognition be affected? Well, we know that the brain is specialised to do lots of different tasks, but it's not that the whole brain is involved in everything. So this part of the brain here is really important in terms of coordination and walking. This part of the brain's more important for navigation, knowing where you are in the world. This part's particularly important for memory. And the anterior temporal lobe that we saw earlier is really important for language, so understanding words and meaning. And it's this frontal lobe and the temporal lobes of the brain that are important for social cognition. So if these parts of the brain are damaged, then people are going to have problems in terms of these social cognitive skills. And we know that these are almost exactly the same as the regions that are affected in frontotemporal dementia. So in all of these three subtypes, the behavioural variant, semantic dementia and progressive non-fluent aphasia, the parts of the brain, so the frontal and temporal lobes that are affected are the same as those in social cognition. And you saw someone's MRI scan earlier from Rebecca, but here you can see a healthy person's brain looking at this frontal and temporal region of the brain, which is important for social cognition. And this is someone with frontotemporal dementia. So you can see there's really significant shrinkage in these parts of the brain that's responsible for things like recognising faces, empathising and so on. So if there's nothing that you don't, if you don't take anything from this talk, the one thing I would say is that all of these symptoms are because of shrinkage in these parts of the brain. It's not in response to how they feel about you. It's not in response to how well you're looking after them. It's because it's part of the disease. And it's just the same as the memory part of the brain being affected in Alzheimer's disease, the social cognition part of the brain being affected in frontotemporal dementia. So as I was saying, we look at emotions in lots of different ways. Emotions can be expressed from facial expressions, from people's tone of voice, from their body language, and even in things like music. So if you think about the soundtrack to Jaws, you automatically know that's scary type of music. So we can express emotions in lots of different ways. How do we actually assess it here? Well, one of the ways we do it is to show people faces and ask them what emotion the person's expressing. So does anyone want to have a guess at what this emotion is? Anger, yeah, I can hear a few angers. So again, it might not feel quite natural to you to think of the label to match with it, but I think as soon as you see this, you're sure the person isn't happy, they're not sad. And so what we know is that in healthy people, they find these types of tasks very easy. So they get them right about 90% of the time. But in people with frontotemporal dementia, they really struggle. So you can see they're getting between 60 and 70% right. So a lot of the time, they're not actually interpreting the emotional expression correctly. And that's true for all of the three subtypes. We also know that negative emotions are more difficult for them to understand than positive emotions, so they tend to still be able to recognise happiness, but things like differentiating between anger and disgust and sadness are much more difficult for them. We've also looked at other aspects, so looking at empathy and also social conformity, so that's things like knowing how to behave appropriately in public. And what we did was actually, a lot of you might have filled in this questionnaire where we asked carers to rate how people are in terms of their ability to recognise emotions, empathise and understand these social norms. And again, what we found was in controls in the blue, they find these types of things very, very easy, whereas in behavioural variant frontotemporal dementia in green and semantic dementia in orange, they have a lot more problems. And you can see again here, people with Alzheimer's disease don't have these problems at all. So they're rated just the same as controls. What was really interesting is we also asked patients to rate themselves in terms of how well they think they could do these tasks. And you can see they think they're fantastic. And And this is a real challenge for us as clinicians, because if you think about if we're trying to develop interventions or ways to improve people's difficulties, it's really difficult if someone doesn't recognise that they have a problem in the first place. So we need to think a bit more creatively and a bit more laterally in terms of how we can help these problems, which doesn't rely on people having very good insight into their own difficulties. And I guess one of the things with the task that we've used previously is that you don't often go around and see these faceless heads in black and white and ask, you know, are they angry, are they sad? So we've also been trying to use more real life situations. And so I've just got a little video here for you.
The boss thinks I've done well or not this year.
Hey, everyone knows what a great job you've done.
I'd really like to get that promotion.
No doubt about it. I wouldn't be surprised if you're made number one before long. Why not? You've shown such dedication. You've worked such long hours. And you've made so many great decisions.
Yeah, well, I've tried.
Without you, this company would go broke. You're indispensable.
So, does she think he's going to get the promotion? Does she think he's a good worker? No. Exactly. So we've done these sorts of tasks with people with behavioural variant frontotemporal dementia, and we show them these videos either like this, where they're saying things sarcastically, or saying exactly the same information sincerely. And what we find is when they're being sincere, they can understand what's happening perfectly well, so they understand the conversation, they know what's going on. But as soon as there's this element of sarcasm, all of a sudden they don't understand. So they interpret this on face value. They will say, yes, she thinks he's a good worker, yes, should definitely get the promotion. So they don't understand these subtle non-verbal cues in terms of prosody in the same way that we do. So what does this mean in everyday life? Well, we know from all of the research that we've been doing that people with frontotemporal dementia don't understand these social cues in the same way anymore. And so I guess if you think about it that way, it's not surprising then that these social situations are really confusing, because you don't know if someone's angry with you, you don't know if someone's upset, and so then you respond in a strange way. And also, if you don't understand things like sarcasm, you might react unpredictably because everyone else seems to think it's very obvious what's happening, but you don't really understand. One of the other challenges is that these difficulties contribute to misdiagnosis and inadequate management. So like I said at the beginning, the normal tests of cognition that people do for dementia, actually people with frontotemporal dementia can do quite well on. So that's why we're doing a lot of work to demonstrate these problems in terms of social cognition, so that when people in future go to their GP or go to a psychologist to have testing done, they incorporate these social cognition tests, which will uncover the problems and uncover the impairments, which we hope will mean that people get diagnosed earlier and more accurately. So, any questions on social cognition? Yeah?
Is that why when they're in a situation they don't understand, maybe why people are laughing or whatever, they can become quite aggressive and act out on that?
Yeah, so I think we don't exactly know, because these symptoms are so complex, how one thing causes another, and that's certainly something that we're trying to research now, is to see what leads to this aggression or irritability. Is it because of social cues? And if we help them understand the social cues better, could that improve their behaviour in social situations? So we've spent many years and a lot of time trying to demonstrate that they have these difficulties, and now what we're trying to do is work out how we can fix it and how we can try and get it to benefit other social behaviours as well. Yeah. All right, so I know I'm keeping you from lunch, but I just wanted to talk about two other important symptoms. So this is sort of looking at some of the case files that we've been collecting over many years. So like Olivier said, we've seen around 600 people, and we've just done a study looking at around 500 people with all different types of dementia, and looked at what we call irrational beliefs or delusions. And these are some of the symptoms or some of the irrational beliefs that people were reporting. So things like they think their wife is ripping them off, they think the neighbour's trying to spy on them, those sorts of things. And what we found was that when we look across all 500 people that we've seen to date, that it occurs in around 10% of people. So they have these irrational beliefs or delusions. But it doesn't happen the same across all of the different syndromes. So it's much more common in the behavioural variant of frontotemporal dementia. So if you've got the behavioural variant, you're 3 times more likely to have these delusional symptoms than the other subtypes. We actually had no one with progressive non-fluent aphasia that had these types of delusional beliefs, and it was also very rare in semantic dementia. So it seems to be something that's specific to behavioural variant frontotemporal dementia and affects around 18% of people with behavioural variant FTD. The reason that I wanted to talk about it today is to give you some ideas, first to say this is also part of the disease, and so if you notice these sorts of problems, it's something that we've recognised now as an issue. In terms of what to do about it, the first thing that we would say is investigate the suspicions to check if they're accurate or not. So I certainly don't want to give people the impression that you can't believe these people or that they don't know what they're talking about. The first thing that we need to do is check. So if someone's saying that that someone's stealing money from them, for example, we want to check that that's not the case first. But if you can't find any evidence for these irrational beliefs, we know that trying to rationalise with people doesn't really work. So they're going to believe these things one way or another. So trying to convince them that it's irrational isn't really effective. But what you can do is try and work out the patterns in the behaviour. So if someone thinks that people are stealing things from them, for example, it might be because, you know, their wallet's being moved around the house all the time, and so they don't know where it is and think that it's being taken from them. So if you can identify patterns and then change the environment in some way, that seems to be really helpful. So if it is things like people stealing money, then making sure their wallet is in the same place all of the time seems to be much more effective than trying to just rationalise and argue with people. The final symptom that I wanted to talk about was apathy, or a loss of motivation. So we know that apathy is the most prevalent non-cognitive symptom in dementia. So after problems with language and so on, apathy is the next most common, and it affects around 90% of people at some point in the disease course. So really importantly, it's not the same as laziness. So just because people are less motivated, it doesn't mean that they're being lazy. It's because the part of the brain that drives us, that gets us out of bed in the morning, that gets us interested in doing things, is shrinking. And so they don't have that same drive that we all have. It can affect people from mild to more severe. So at the very mild end, it might be a loss of interest or in hobbies, and at the more severe end, people might lose motivation to even shower or dress themselves or eat. And so far, there's been very, very little research on apathy in dementia to date, and so we've been very fortunate to have a grant from the government to focus specifically on this symptom. And what we've been doing is looking at apathy in a much broader lens than what's been done previously. So previously people have just said apathy is there or it's not. But what we've found is that actually it's not just a matter of apathy being there or not. it's very complex in terms of how it manifests. So for some people, it might be more in terms of reductions in their emotional expressions. For other people, it might be more problems in terms of difficulty planning and organising themselves to implement things. For other people, it might be more social withdrawal. And so we've started looking at these more precise definitions of apathy in people with frontotemporal dementia, and we've found that the profiles differ across different subtypes. So in behavioural variant frontotemporal dementia, it seems to be more this affective or emotional component of apathy that's affected. So emotional indifference or blunting, loss of expression, those sorts of things. We're doing studies at the moment to see what's happening in semantic dementia and progressive non-fluent aphasia. And the reason it's important to take this more holistic approach is because we think that the interventions are going to have to be different depending on what type of apathy symptoms it is. So if someone's having problems in terms of organising themselves and planning things, how we treat that is going to be very different to if it's more emotional indifference. So that's the work that's currently underway, and we're focusing on understanding this symptom in a lot more detail and also developing interventions. So I just wanted to highlight that we recognise that this is a problem that a lot of people are dealing with, and it's something that we're really working closely on. So just to finish off, why is research on social cognition important? Well, firstly, as I said, we think it's going to help improve early and accurate diagnosis, mean that people aren't being misdiagnosed with Alzheimer's disease or with depression or stress. And so by developing these tests, we hope to roll them out more broadly so that people are tested earlier and you don't have that delay in diagnosis, which we know is a real difficult period of time to deal with. We also think it's really important in terms of helping people understand the symptoms, not just for people like family members like you, but also health professionals and the general public. We want to raise awareness so that when people think of Alzheimer's disease, they think of memory problems, but when people think of frontotemporal dementia, they understand it's not a memory issue, that it's changes in social cognition. And hopefully that will mean that there'll be better support in the community for people with dementia and also their families. And also we're hoping that this information is going to help us develop more effective interventions. So I know we're going to talk a little bit about drug trials, but what I'm really interested in is how do we help people now? Drug trials are 5, 10, 15 years down the track, but I think there's ways that we can really help manage these symptoms a lot more effectively. So that's really something that we're working on closely now. So to finish off, I just had a few tips in terms of how to manage these changes in social cognition. I guess the first thing is really from your part, perhaps changing your expectations. So knowing things like people might express themselves differently, they might become more distant and cold, they might have these strange behaviours, but it is due to the brain changes. So I would say, manage your expectations, treat it the same way as people treat memory problems in Alzheimer's disease, and be aware of what people are able to cope with and what expectations you're putting on them. There's also ways that we can improve communication between you and the person with dementia. So things like our research shows, sarcasm isn't going to work. If you use things like sarcasm or very subtle emotional cues, they won't understand you at all. So I think trying to be very direct in your communication, explaining exactly what you mean, will really help that they can understand those social cues as much as possible. For us, we rely on these very subtle micro expressions, but that's not really going to be sufficient for people who are having problems in terms of understanding what emotions are. And I guess for the language variants, often social interactions can be really challenging, either because they don't understand what people are saying to them or they can't express themselves anymore. But a lot of the way that we communicate and spend time with people can be non-verbally as well. So don't focus just on conversations, think about other things you can do. The other thing for both you and the people you care for is try and stay connected. I know it's easier said than done, but Social isolation can really increase burden, so take the opportunity at lunch to chat to people here today who experience the same things as you. Also, for the person you care for, try and find shared interests that can maintain connections. So a lot of people get pleasure out of things like doing art together or going on walks together. If you can find activities that you like to do together, then hopefully that can help maintain these social relationships as much as possible. And yeah, try and identify activities that the person is interested and likely to engage with is really the best thing we can do in terms of managing motivation and apathy at the moment. But like I said, stay tuned. We're hoping to move more into that area in future. So that's all from me.